Mazar.
That's me.
Please go ahead.
Hi, good afternoon. Thank you for having me here. And this presentation is about an objective classification of the nomenclature of minimally invasive surgery. As you can see, the only financial disclosure I have is this jacket and tie belongs to my colleague, Dr. Ali Kindawi, sitting here, as I lost all my luggage during my travel. Okay, and I've traveled here all the way from Doha. As you can see, it shines by day because the temperature is about 115 plus Fahrenheit. That's 45 degrees centigrade, but it's bright by night as well. This is where I work. It's never as desolate. This is a corporate file picture. And we are the only tertiary care center there. We have established VATS program, and this year we have started our thoracic robotic program. Now, this presentation is about an overview, some searching, and some soul searching. What this whole activity of minimal access surgery is about, if you look at it, it's all about the outside, the shell. It's how we crack into the thoracic cavity, and we get inside and do the job. Inside is more or less the same. It's the same cutting, burning, peeling, stitching, or stapling. So the difference on the outside, the methods we use, and the means to achieve the instruments which we use. So an objective nomenclature system should have a clear definition of what is minimal and what is maximal, and then within the minimal, because minimal deals with the small things, should have a precise minimal access stratification nomenclature. Now, unfortunately, when you look at the literature nowadays, it is in a disorder. Not only disorder in titles, but disorders in techniques. Now, I give you an example very quickly, as I have very limited time, that in titles, for example, people call it VATS, some call it MITS, minimally invasive, some call it minimal access thoracic surgery. Now, when an ESCTS survey was done, many of you must have seen this in 2007, and then you can see that 1/3 of the surgeons would regard all of these as the watershed between an open surgery and a video assisted, which is a synonym, supposedly, for minimal access surgery. So the length of the skin incision, the intercostal incision, whether you divide the chest wall or not. And that not only, that's not where the matter ends. There is a lot more variation in the details. For example, the largest incision which you do during minimal access surgery, there are various names. And you can see it's called utility port, working port, access thoracotomy, utility thoracotomy, and the length could vary anywhere in published literature from up to 10 centimeters. Then whether you have a direct look through the wound, whether you look only at the monitor, whether you cut the muscle, or you use the spreader or not. So it's not only a matter of semantics, because just to recap, it's all about little pain, which leads to all the other things. Lesser length of stay, better, quicker return to work. So if that is the crux of the whole minimal access surgery, then we should have a homogeneous system whereby you can compare the results of different procedures by different surgeons exactly and precisely. And so one could ask a legitimate question. And if I ask, I'll get, I'm sure, and if you ask to another audience of this profession, you will get very varied answers. What is an open operation? What is a closed operation? And where does this large 10 centimeter, for example, access port differs from a mini thoracotomy incision? What is a large thoracotomy incision? So we need to clearly identify these. Now let's take the stocks for a second. Everybody agrees that if you do an operation with puncture holes, which allow only a video instrument, one instrument at a time, and you look at the monitor and you finish your work, it is a video-assisted thoracic surgery. Everybody would agree that if you open, put your hands inside, your head inside the chest cavity, it is a thoracotomy. There is no confusion about it, and you use all kinds of instruments. So there are two things, the hole and the instruments coming up here. Now, so the watershed, to my mind, is the human hand. That's when once it goes inside the cavity, is a maximal invasive operation. If it doesn't go inside, then probably we are talking about not maximal invasive. We'll clarify that in a second. But there is a gray zone between the two, isn't it? That's where we require some stratification. I have humbly attempted to categorize this on the basis of the size of the skin incision, which is relevant to the surgeon's hand on the basis of the anthropometric data. Whether you use a spreader and what kind of instruments do you use. These are the 4 criteria. Now, kindly look at it for half a minute. Now, this has been collected from some very unorthodox sources and sites. NASA has got a great pool of data on human hands because they need to build and have an inventory of very precise gloves. Georgia Tech makes instruments. The engineers need to know exactly hand dimensions to produce instruments. Belgium had a population anthropometric data published on that. Palmists, who are serious, they go around and chirognomancy, they call it, and they look at the dimensions and the sizes of the hands. Now, if you look at that, on this column, the largest hand, complete hand, the thumb's breadth is this, and the palm's breadth, about 12 centimeters is the largest. If you look at the smallest, you will say, okay, 7 plus 14, it's about 8.5 centimeter is the female hand. Now, these are flat hands, not folded hands. When we go through a hole, we go in there, because even Mike Tyson has a wrist smaller than his flat of the palm. So if you have this much hole, you can get in there, and then still you will have some space. So arbitrarily, because you have to draw a line somewhere, I see that on an objective basis, a greater than 12 centimeter incision will allow the hand of the male surgeon with the broadest of the hands. Now, so the proposed classification is around 3 titles. I call it a thoracoscopy, which I will explain in a minute. 2 subcategories with simple VATS or incisional VATS. A thoracotomy, which is either minor or major thoracotomy. And in between the two, I suggest a hybrid terminology. A thoracotoescopy is a tongue twister. Okay? Now, this is the crux of my presentation. If you look at this, these were the bases on which this classification was built. And you can see that it is a kind of a smooth transition that if you have less than 2 centimeter holes, and this is the kind of thing you put in your instruments, and you do all the operations, you do only VATS operations, instruments, you can't put in, for example, a swab stick and go on and do hemostasis, and you don't use a rib spreader, and of course, no hands go inside the cavity. If an incisional VATS, you can use with the VATS instrument some non-VATS instruments. A small rib spreader a small lung, retractor can go down. You can have a couple of swab sticks in there and helping you out. In this, if you have 12 to 18, it's classified as mini thoracotomy. It allows 1 hand plus. And if you have much more than that, then of course, it's a major classic or standard thoracotomy. In between is this gray zone where you can use both kinds of instruments and you can use a small spreader. I use a small modified pediatric spreader to 3 tons, and I didn't find any difference. And this is an example of our 100 non-oncological cases. Now, you can see that you could make it, collect it together, make it coarse, or make it fine-tuned. And you can have all your report in your registry as how many VATS, how many ports were done, and if incisional VATS, what was the length, and if thoracotoescopy, what was the incision, and on, so that you can compare at the end of the day various kinds of data. In conclusion, I would say that this gives you an easy and objective method whereby you can categorize and your operations and you can compare the results of various surgeons. These are the references. It is going, perhaps, it will be published in Innovations. Thank you very much.
Okay, thanks. So we have lots of time left for discussion.